Hey everyone, this is Tom Salemi. Welcome back to the Device Talks weekly podcast. We've got a great episode for you coming up. We're going to speak with Andrew Jay. He's a general partner at Borna Health. He'll join us for the Newmarker's Newsmakers. And later on, I'm going to play our most recent MedtronicTalks podcast. I'm not sure if you folks have had a chance to listen to it. It's centered around healthcare inequity, and it's an important issue, one that keeps popping up. So I wanted to play the entire episode. So you're going to hear the whole thing, start to finish, theme music, sponsor messages. You'll hear that episode just as it came out. So I know you'll enjoy the insights presented by Karen Shahady and John DeChapel of Medtronic. So I won't say much more since, again, there's a whole episode within an episode. It's kind of like one of those Russian dolls waiting for you a little later in the podcast. So we'll hear from Andrew Jay first. We'll hear from the folks at Medtronic a little later. I'm also going to connect with George Strom. He's Business Development Director of IoT at Intertech. We'll talk about another piece of news that I wanted to highlight that fell outside of the Newmarker's Newsmakers list. Before we begin this episode, though, I wanted to give you just a quick update on where we are in all things Device Talks. I'm working on the agenda for Device Talks West. Registration for Device Talks West, which is happening on October 19th and 20th, actually starts on Monday. So you can register starting then. Of course, there's an early bird special going on right from the start, and it'll go on for a few months. But do keep an eye on the website, Device Talks, or the actual website is west.devicetalks.com. But just go to devicetalks.com. You can find the page for West. We've got some great keynotes up there right now, but I'll be building out the agenda in a bit. While you're at Device Talks, you can also check out our upcoming Device Talks Tuesday sessions. They're restarting again. We will be back not this Tuesday, but the following Tuesday, the 14th. We'll have a session brought to you by Intertech. Following that, the following week, we'll have a Device Talks episode, Device Talks Tuesdays episode brought to you by Pulse Technologies. And then we'll have Resonetics. And then July, we'll have presentations by Sunrise Labs and S3 Connected Health. And that will conclude sort of our spring, summer season of Device Talks Tuesday. But we'll be back in late August, early September with more. So Device Talks Tuesday is rearing back. Go to devicetalks.com to check out what these great companies are talking about. Finally, our podcasts continue to roll out. We put out our Stryker Talks earlier this week. I hope you saw that. That goes out through our Device Talks channels. You can also, again, subscribe to MedtronicTalks. That's on its own channel. And keep an eye out for an Intuitive Talks. Should be coming out in a few weeks. We'll bring that to you as well. And as well as a couple of Medtronic Talks will come out this month. Speaking of Device Talks Weekly, I am working on a few episodes. We'll be looking at companies in the medtech space, trying to take a deeper dive, talking to multiple executives within the same company. So I hope to bring you episodes centered around companies like Fractal and Cala. And I think I'm enjoying the conversations that I'm having with executives here. It's giving me a chance again to ask more detailed questions about their jobs and what they do. So I hope that'll bring you even greater insights into the medtech industry. So that's a lot. Thanks for your patience and thanks for listening to it. Once again, Device Talks West happens October 19th and 20th. Please circle those dates and check back at devicetalks.com for the agenda. I hope to have an updated agenda, a complete agenda to you by the end of this summer. So keep your eyes peeled. We definitely want to see you there at the Santa Clara Convention Center. All right, you ready for this?
Ready.
Chris Newmarker, how are you, sir?
Hey, doing all right, Tom. It's been a crazy few weeks in the news, hasn't it?
It really has, and it's why we brought in our third person in the booth. We have Andrew Jay. He's general partner at Borna Health Fund, a hedge fund in Boston. Andrew, you and I have known each other for a few years, going back to Siemens and beyond, I think, too, right? You were doing corporate VZ for them before.
Yes. We at least 25 years.
You had to say that out loud. Yeah, it's been a while. Tell us a little bit about Borna, and then we're going to get into our Newmarker's Newsmakers.
So we're a healthcare dedicated hedge fund, and most of what we do is in the medical technology sector.
Fantastic. And how long have you been doing that?
About a year and a half now. We have money from family offices in Boston, Pittsburgh, Minneapolis.
And I've started watching I've started watching Billions. I imagine it's just like that. You're just like Bobby Axelrod.
No, not yet.
You're like,
How big's your boat, Andrew? Is it as big as Bobby's?
No boat yet.
no boat yet.
Fantastic. Well, like we said at the top, we brought you in because you're actually following the stock market. We have a lot of public-oriented topics on the Newmarker's Newsmakers this week. So I had already given sort of a recap of where we are with Device Talks prior to opening this segment up. So Chris, why don't we just roll into number 5?
Yeah, here we go. All right. Well, number 5 on the list, we've got Stryker's spine guidance software won FDA clearance. It's their Q guidance system for advanced surgery planning. I mean, this story is getting a good amount of attention on Mass Device. I mean, it just seems like just another thing that Stryker is doing to further burnish this kind of like digital surgery, robotic offering that they've really been building in recent years. That's really done them well.
Yeah, well, we had them presenting at Device Talks Boston about their digital strategy, and Chris called an audible threw this one at us at the last minute this morning. So Andrew, I don't know if you had a chance to review it, or if you have any thoughts just general on Stryker's approach on digital surgery and robotic surgery.
Well, Stryker's been doing an excellent job in this field. In orthopedics, I think their robot is one of the strongest offerings. And the whole idea is you surround the physician with these tools, and through that, you get the hardware. And so they're just doing a great job. Absolutely.
Yeah, and I think they said at their annual call last year that I think it was half of their surgeries are being done with the robot. So it's really gained critical mass. So
exciting.
It's we've got the Stryker Talks podcast, which went out yesterday. That was focused on their neurovascular business. Lots of exciting stuff happening there at Stryker, and good news for them on this 510(k) clearance. All right, Chris, what's
very cool.
What is number 4?
Well, number 4 on the list, we've got Quidel completing their $6 billion acquisition of Ortho Clinical Diagnostics. Just further expanding what they're doing in the diagnostic place. They've been a big player with COVID-19 tests in recent years. So just we've been asking, like, are mergers going to slow down with, inflation and market turmoil and, worries about whether we have a recession or whatnot. And, here we do, we got a big $6 billion deal.
And that is a huge deal. And before we get into the details of the deal, I always thought is it Quidel or is it Quidel? Andrew, do you have any insights on the pronunciation?
Quidel.
Mm-hmm. All right. You were closer.
Quidel.
Points to Newmarker for that one.
Cool. You know what? I asked Google.
Oh, well, by all means.
I did some extensive research, Tom. I asked Google before the call, like, how do I pronounce their company's name?
Well done, sir.
Yes.
Coming prepared. Andrew, what's your take on the deal? It's a huge merger.
This is interesting because this is COVID having exactly the opposite impact as one would expect, because the COVID testing revenues have drone Quidel revenues up tremendously. In the first quarter, they were $1 billion, up 167% year over year. And COVID testing drove that. What they're doing is something that's really smart. They're taking the profits from that and reinvesting that money into M&A to grow the business. And this acquisition makes them a player. It gives them access to the central lab with automated systems, with clinical chemistry, recurring revenues. So it's really a transformational acquisition for them. It takes them from being kind of a niche flu test player to really being a significant diagnostic player.
That reminds me that, Hologic's been doing a similar strategy as well. They got, a bunch of COVID money in, and they've been going shopping, doing all these tuck under acquisitions and acquiring technologies. So yeah, it sounds like you can go shopping if you've been, selling a lot around the pandemic.
And we'll talk about the mergers and acquisitions environment a little bit later. But is there anything in particular that's present within the public market or characteristic of the public markets today that are making big deals like this more possible? Is it just the surge that we had previously seen in the values of stocks that make deals like these more likely?
That's a good point. What we've seen across the sectors is the multiples contracting. So if you go back 6 months, it was very common to see companies trading at 10 times revenues and as high as 20 times revenues for high growth companies. And now the range has come in significantly. The fast growing companies are now valued at about 10 times revenues. And there's a number of companies trading for less than the cash on their balance sheet as you get down to the smaller end of the universe. So all of a sudden, companies that previously were, oh, that's too expensive to buy.
Oh, interesting.
Are now, gee, well, maybe we can afford that. Maybe we can make this work. So the environment has changed from a
that's cool.
affordability perspective.
From a buyer's perspective, do they still have the funds necessary to make those deals? If the prices go down, they're going down for everybody. So those who maybe if they have the cash is cash. But if they were going to buy it with stock, they have less buying ability than they did before. Does it kind of even itself out in terms of buyers and sellers?
Well, to an extent, but the cash is cash. And even though interest rates have moved up, they're still very, very low. So if there's a deal to be done, there's generally financing for it for a company with cash flows.
So we could see more of these. So it's a buyer's market.
Nice.
All right, Chris, I love number 3. Let's roll into number 3.
Hey, number 3 on the list, we've got, Medtronic. Well, to start out, Medtronic, they had Q4 earnings that missed the street. They're really wrestling with some supply chain problems right now. It's a problem in general for many companies, but they especially have, some supply chain problems they're working through. But, at the same time that they had these Q4 earnings, they had this really interesting news that they're, spinning off their kidney care company, and they're going to jointly own it with DaVita. So Medtronic and DaVita are going to be partnering to create this new renal care solutions business. There's been a lot of talk about whether Medtronic was going to start divesting some stuff to kind of get more streamlined, and this seems to be, it'll be interesting to see what else comes out of what else Medtronic does, but this definitely seems to be a move they're making right now to, they're going to, partner with DaVita to start this renal care company.
So this is a good move. Medtronic has a problem. First quarter, the organic revenue growth was 1%.
Yeah.
So it's hard to outgrow the market when you are the market. When they acquired Quidel, they acquired a lot of different business units. And so it makes sense to spin this one out. The dialysis center is not a core customer for them. It's not a key business for them. They weren't selling really high value products. So this is an opportunity to get this business off their income statement. They're not going to invest in it themselves. So it is the first step, and I believe what will be several steps of taking businesses that are either not growing or not strategic and finding new homes.
Yeah.
Is this the other shoe in regards to Medtronic's reorganization last year, where they split up into the 20 operating units? Was that sort of a first step to identify those units which maybe aren't going to be along for the ride? I
don't know if that particularly was a design step to do that, but it certainly helps you facilitate where the pieces are that aren't growing, or that where the chunks are that you need to pull them out and begin to identify them, get them to think independently so that they're more easily identified and more easily segregated.
I've noticed in the analyst notes, they've been kind of pushing them to do more of that. They're kind of like, hey, that diabetes business, why don't you, we're seeing kind of those suggestions coming out of the analysts.
No, it's certainly an interesting time. And in the diabetes space, the renal space.
Sorry, Tom.
The renal space, it's one where we've seen a lot of change too in how it's delivered. We're seeing a lot more at-home dialysis. It seems to be an area that's in flux. Do you, at least to me, do you see it that way as well?
I do. And there's some great technologies coming out and for at-home use, and also simplifying the process even within hospitals, which is good for diabetic patients ultimately, because the easier it is, the more convenient it is, the better off the patients are. You can administer the therapy more frequently, which gives better outcomes. And so it's a win-win for everyone.
That kind of dynamic situation, a smaller company can sometimes do better. Every once in a while, a big company does something really, wow, you did something innovative. Medtronic did that with their micro-leadless pacemaker, but a lot of times a smaller company can be a little more nimble and figure things out, it seems.
Yeah, we had Leslie Trigg of Outset on. They're obviously doing some good things. And I know Fresenius made a deal recently that was changed things up a bit. We've been trying to get them on the podcast, so I don't have particulars on that, but seems to be a lot of movement in the renal space for sure. Chris, let's roll into number 2.
Hey, well, number 2 on the list, we had Masimo shareholders in their recent meeting. They voted no on the way the company's been handling executive pay. Now, this was an advisory vote. These stay on pay votes, they don't require the board to do anything, but it's kind of putting the Masimo board on notice that they aren't at least a slight majority of the shareholders are not happy with executive compensation. And, this is really interesting. It's become a trend. I mean, we had say on pay votes at Zimmer Biomet and Henry Schein, where the companies did win them, but it was a pretty narrow margin. I mean, usually the companies get 80-90% of the shareholders saying yeah, the compensation's fine. And now, they're barely winning, or in the case of Masimo, they're losing. And, the Wall Street Journal had an interesting report recently pointing out that actually there are dozens of companies across all kinds of industries where this is happening, JP Morgan, Intel, Coca-Cola. It kind of seems that, in the past, it was just all about the bottom line and, financial performance. But, you're seeing more investors and shareholders saying that they want to, they have opinions about the way the executives are paid, and they have opinions about the environment and about, what the company is doing with social responsibility. So it's an interesting trend.
Yeah, this is one of the areas, Andrew, that we really wanted you to bring some insights on, because you can just it's clear that this is across industries, as Chris said, but I also don't know if this is just sort of some expression of frustration from shareholders overall, or if it's a concerted comment about executive teams across industries or in medtech in particular. And since you're one of these investors, we'd love to understand how you're viewing all this.
So I see this as being, as you pointed out, frustration. Mm-hmm. If you look at the iShares index for medical technology, it's down 20% off its peak from last year. If you look at Masimo in particular, they made an acquisition that is still not clear how it's going to work out, and that did some very significant damage to their stock price.
It was a head scratcher. Yeah, I mean, like high-end speakers, sound united.
So you have an overall kind of dissatisfaction with how executives are paid across the stock market. And then medtech is having a difficult time, so that also amplifies it in that sector. But overall, the executive pay in medical technology is not egregious. There are some examples, but it's not like you'd see in some of the media or communications and some of those other industries.
Yeah.
So the executives generally are reasonably paid, and a large part of their compensation is tied to stock performance.
That was the case with Masimo. I mean, Joe Chiani, I mean, his overall compensation was just up 5% from the year before. And, in his case, exactly, it was mostly, related to, stock. I mean, like stock awards, option awards. I mean, so, he's got to grow the company to, get all this money.
So he's aligned with the shareholders.
So it's interesting. The majority of them though said, no, we don't like this. So it's really I think you're right. Maybe it's something frustration going on. I also wonder, okay, this might be just totally, a bad guess here, but I'll just throw this out as that, right now, we're having economic turmoil. We've got a labor shortage. The old classic thing to do when you had economic turmoil was okay, we're going to let go of some workers and, this is going to save us money. And it seems really hard to do that right now. I mean, because everybody's complaining they don't have enough workers. So, maybe looking at these executive pay packages, maybe that's what the investors are doing, saying hey, why are they making $15 million a year, or $20 million a year or whatever, I wonder if maybe that's part of what's going on.
Well, I think those numbers are those $15-20 million numbers are pretty unusual. And if you cut executive pay, it doesn't really make a difference on the bottom line that much.
Mm-hmm. Yeah.
The numbers individually sound big, but when you spread it over $1 billion business, and from an impact perspective, the way a board works is you have a compensation committee. Okay, so when this vote came through, what they did is they had a compensation study. They had somebody look at executive compensation across the industry, and they said, well, where do we lie?
Right.
And they look at the comps and they say, okay, we're in the middle third, or we're in the top quartile, but the company's been doing better, or, okay, we're going to bear that in mind in future years. It's very difficult to cut the pay of an executive unless there's something drastically wrong with the business.
Yeah.
So where the impact will be is down the road in terms of increases.
I mean, no board's going to want to be like, oh, we lost our CEO because, who was doing a pretty good job just because we didn't want to pay him competitively, like.
Exactly. The switching cost of an executive is enormous because it's going to take you 6 months to find a replacement. You have the chaos. Internally, the organization says, well, we need to make a decision on this, but we want to wait till the new CEO is in place because that person's going to have to live with it and drive it. So it does, the switching costs around an executive change, a lead executive change, are pretty significant in terms of where you're going and how the business is moving. If it's something like syringes, which are a commodity product, you're just cranking them out, then it's just kind of, okay, we keep running the company till we and status quo. But if it's something that it's an active and dynamic market, the CEO plays an important role, and it's having an influx really slows the organization down.
Yeah, you don't want to have nobody at the wheel.
So are votes like these kind of just like and they are exactly that, a non-binding referendum, just an opportunity for investors to ding a CEO or send a message, and that's sort of where it ends?
It's not ignored. The board takes it becomes an agenda item for the board, and they become aware of it. Mm-hmm. And the compensation committee does their kind of individual work and brings on the consultant, and they do the overviews, and then they have it as a discussion point. But it's not. It doesn't lead to, oh my gosh, we need to change something. Mm-hmm. Instead, it's okay. We need to bear this in mind as we go forward, and we're not egregious. We just need to think about this and be cognizant of the optics as we go forward.
I also wonder if Masimo is just the victim of being third, if the other two sort of got some steam going, and then finally this one's the one that kind of got pushed over the line. Maybe not. Yeah,
but kind of felt like it.
Yeah. Do you think we'll see some more of these, or is these isolated votes?
I think, well, given where the stock market's doing, I think there's going to be more frustration, and I think there's going to be more irritation and so a little bit more irritability. So I think there'll be more of these.
I would definitely say, in the past, these shareholder votes were kind of like, oh, we'll check them out if we have time, with our reporting. And in this environment, it's definitely become a lot more like, somebody really needs to look at all the shareholder votes and see what happened with all these companies, because it's interesting things are happening.
Absolutely.
We had the Johnson & Johnson, the majority of shareholders said you need to do a racial justice audit. I mean, that was that was interesting. So yeah, the shareholders are definitely, it's not rubber stamp shareholder meetings going on right now. They're interesting. Who knew shareholder meetings could be exciting? Yeah,
they're being heard. All right, let us move on to number one of the Newmarker Newsmakers, Chris.
Number one on the list is about rumors. I don't know. Would you get sued by Stevie Nicks if you did a little song clip or something?
I'll look that one up. We'll talk to the Device Talks attorneys about that.
There we go. The former members of Fleetwood Mac have shut us down. Who knew? That guy has good lawyers. Anyway, yeah, let's don't do that, Tom. Don't do it. But anyway. You're talking about this environment with mergers. There have been a lot of rumors lately about different potential big, medtech rumors, and one of those was that Dexcom was going to acquire Insulet. This was based off a Bloomberg report where they cited people with knowledge of the matter. I've noticed Bloomberg's really good about finding anonymous sources around who's saying, "Hey, a deal is in the works." So they had one of these, and Dexcom with the American Diabetes Association conference coming up, took the unusual step of actually putting out a statement a few days later saying, no, we're not. Definitely was very lawyerly, but they said, that they wanted to confirm that Dexcom is not in active discussions regarding a merger transaction at this time. So, they said that was done. Another story which is getting a lot of attention on Mass Device was we had one of the analysts who really follows this industry, Needham Companies, Mike Matson, was rating on Boston Scientific stock to buy, partly because he thinks J&J might buy them. He thinks Johnson & Johnson might buy the company. We got a no comment from the companies, of course, off that. But he had a whole thing that he laid out, about how J&J is spinning off their consumer business. He thinks they need to find a big acquisition to make sure that their medtech business is about as large as their pharmaceutical business. And he thought that Boston Scientific would be a good fit for them. This isn't the first time that somebody's made this guess. I mean, actually, Mike Mahoney ran J&J's medical device business, before he joined about a decade ago. And back then, J&J was unusually friendly about him, moving over to Boston Scientific, which caused some speculation at the time, like, oh, maybe there's going to be a merger, because wow, they seem to be getting along right now, which didn't happen. But I know when you heard this, Tom, you thought this would be great, right? You were just clicking your heels.
No, as a Boston guy, I want my Boston Scientific in Boston, or at least as much as it could be.
Like, don't take Andrew, my Boston Scientific away from Boston.
Andrew, this is again, I alluded at the top that there's been a lot of merger talk, and this is another reason why we brought you in, just to shed some light on these discussions. I mean, Mike Matson is great, and we will hope to have him on the podcast in the future. He knows the industry. When you see something like this, do you see it as there being some fire that's generating smoke, or is this just more of as Chris said, sort of a continuing of an old storyline? How are you viewing things?
So I look at this as part of an ongoing speculation, in that it does make sense for J&J to move into those pacemaker defibrillator markets. For J&J to grow that device business, they've got to acquire something with significance. And Boston Scientific is a significant player in a desirable market. I do know that years ago, the J&J looked at buying St. Jude and couldn't get it past their main board. So they do have an interest in those markets. They're profitable. They're natural oligopolies. At one time, J&J was a big player in interventional cardiology, the first coronary stent. Mm-hmm. So they know these markets that Boston Scientific is in. They know they're profitable. So it would make sense to move into those. And it is a big company. From a background perspective, I wonder, when Peter Nicholas was alive, I just didn't think a transaction like this was likely, because I believe that he always viewed Boston Scientific as his creation and wanted it to be kind of alive and vital. So it's, with his passing, transaction like this may be more plausible.
Interesting. That hadn't occurred to me, that there just might be an opportunity that was the door that was previously closed is now open on a deal like this.
Not that he wasn't the controlling shareholder, but he certainly was influential on the company, and I think he certainly had the ear of many people about that. So him now no longer having that voice could change the dynamic a little bit.
Yeah, just passed away in mid-May at age 80.
So what is the Johnson & Johnson's need? They just need to find faster growing businesses someplace?
Exactly. If they need to get bigger, they need to move into large markets, and there's not many large markets left that they're not involved in.
Yeah, no, that's an interesting point. All right, well, yeah. So how do you see this? Do if we were to talk again in a year, do you see a deal happening, either this deal or another deal by J&J?
I see probably another deal. I don't think this deal's too likely to happen, but you never know.
You never know, right?
All right. Well, we'll keep an eye on that. Well, this has been really, really enlightening. I'm just curious overall, how do you see things, the public markets, medtech wise, going forward? Before I pushed record, you shared that you got a sense that we may not have found bottom yet. What does the summertime look like?
Wait, we're not at the bottom?
That's what I said,
Chris. So when can I look at my 401k again?
Yeah, right.
Well, there's an old expression which is sell in May and go away. So we're going into months, which traditionally are kind of a lackluster period for the market overall. And I think what we've seen with MedTech is MedTech rolled over first, and then the rest of the market has since followed MedTech. And part of the reason was why MedTech went first. It was, we had the COVID boost when everybody wanted to be in healthcare when the rest of the economy cooled, and now MedTech became moved out of favor. And now kind of the whole market's just having a difficult time, and the medical technology sector and healthcare to a certain extent is caught up in that. I think it's going to be hard for healthcare to really take off as an investment sector until the market at least finds stability. The good news is that MedTech's a very profitable market. Demand is there. We're all getting older. Yeah. Most of us are getting heavier. And as you get older and heavier, you need more medical care and more medical devices. I'm working on it, Andrew, but thank you for pointing that out.
Excellent. All right. Well,
I should go get a burrito for lunch today to help out the medical device industry.
We're helping out. Exactly. Right. We're doing our part, Chris Newmarker, you and I. That's great. Well, where can folks find out more information about Borna? Are you out on social media? We do have a website, or you can find me on LinkedIn, and we'll connect that way. Awesome. Great. Well, this has been very enlightening and fun, Andrew. We'll definitely have you back.
Yeah, all very cool.
Thanks, Tom.
It was nice having somebody knowledgeable.
Oh, man. Hey everyone, Tom here. I mentioned up at the top I had a news item of my own. I was sort of struck by the U.S. Cybersecurity Infrastructure Security Agency releasing advisories on two products put out by BD. According to the article written by Sean Hooley, these were centered around vulnerabilities with BD's Pyxis automated medication dispensing system and the BD Synapsys microbiology informatics software. So cybersecurity, of course, is a big issue. And I wanted to speak with one of our partner experts, Intertech, which is coincidentally putting out its Device Talks Tuesday episode. It'll be centered around cybersecurity. And I had a chance to speak with George Strom. He's Business Development Director of IoT. We did not speak specifically about BD. We didn't want to speak specifically about BD, but I asked George a few questions about the state of cybersecurity within MedTech. And I wanted to get an understanding of what folks who registered for the upcoming Device Talks Tuesday would learn. So let's hear from George Strom. Again, he's Business Development Director of IoT at Intertech. So, George, we saw some news this week on the cybersecurity front and the risks that presents and cybersecurity threats present to medical devices. I know at Intertech you're working on this with a number of device companies. How much of an issue has this become for device companies as they file for approval from the FDA? What sort of steps are they taking? What hoops are they being required to move through?
The FDA on April 8th released new requirements for pre-market requirements directly related to cybersecurity. And within that document, they talk about vulnerability management plans. And they recommend that the manufacturers submit the vulnerability communication as part of their permanent submissions. So this is a major shift on a pre-market requirement, as now the communication plan must include everything from the sources and methods and frequency they monitor and identify the vulnerabilities, as well as periodic security testing to test identified vulnerability impact. So within software, all software has vulnerabilities. Not saying that you should not have vulnerabilities in your software. What they're stating is that you should have a methodology to address when that vulnerability becomes a threat and how you handle that threat and how you go about develop and release patches to that threat and how you update your process and have that patching capability.
Are patches and steps like that something that device companies have to plan out for in advance and have at the ready? I imagine if they have a patch at the ready, they would just patch it. Or is this something that's typically done on the fly after the weakness is found?
No, they have to have a process for patching, and it could be everything from over-the-air updates to having a technician go to the actual device. Possibly it's a portal where the manufacturer, the end client would then go to the portal and download the patch, but they must have a process for patching.
And how big of an issue has this become? Clearly, we hear about it globally and across all industries, but for medical devices in particular, cybersecurity, I imagine, is a growing threat. Do we have any data to sort of suggest or the scope of the problem, or any information of any kind to kind of give us a sense of what direction we're headed?
The problem has become very pervasive, and it largely dovetails from the growth of connected products onto the inpatient bed, as well as the growth of home healthcare products. Those are probably the two biggest arenas we're seeing clients with questions. But what we're also seeing from the regulators back to the clients is the amount of cloud-connected devices represents a threat vector that wasn't previously there for medical device clients, and where the data is stored, and is that patient data secure, and could that data be then taken away by somebody, or the IP of the product. So those are really the drivers, is the growth of cloud-connected products packaged with remote monitoring, packaged with how devices are now moving into different non-traditional arenas, non-secure hospital settings, if you would.
Excellent. And I know you're going to be addressing a lot of this on the Device Talks Tuesdays that's coming up on June 14th at 4 p.m. What are some of the other issues or other pieces of information that people might get from the Device Talks Tuesdays that's coming up?
Well, I think an important factor for a lot of manufacturers is to understand the growth of regulations, but also how they're integrating if they have wireless connections or even USB ports on the device, and to plan for that cybersecurity and not try to plug it in. And this is very much so the cornerstone of what the FDA is advocating, that you have to have a plan and a threat model of what will happen to your device. And that's really very critical for device manufacturers to understand, is that if they go to a regulator such as the FDA and they don't have a plan and they don't have objective evidence, a third-party test report, the likelihood of that tech file being kicked back is very high, and the FDA will be very prescriptive of what you would have to do as a manufacturer. Equally, we'll be covering topics such as traditional connectivity, such as the integration of Bluetooth or Wi-Fi onto your product, and the regulations you have to follow for that approval, as well as wireless coexistence with our experts on the Intertech staff.
Great. All right, George. Well, thank you for the insights on the news of the week, and look forward to talking to you on June 14th on Device Talks Tuesday.
Absolutely. Thanks for the opportunity. I look forward to it as well.
All right. Well, I hope you enjoyed that conversation. Once again, you can register for that discussion at devicetalks.com. And while you're there, you can check our other Device Talks Tuesdays episodes coming up in June and July. Now it's time for our podcast within a podcast. Let's hear our latest Medtronic Talks podcast episode. Hi, everyone. This is Tom Salemi of Device Talks. Welcome to our second season of Medtronic Talks. In our first season, we spoke with the leaders of Medtronic's operating units to better understand the direction of each of the businesses. Now, with their courses set and clear, we're going to talk to the engineers, scientists, physicians, and other experts who are executing on these strategies. We'll still keep a tight focus on each of Medtronic's businesses, but we are going to get a lot deeper into these stories. Let's go. Hi, everyone. This is Tom Salemi. Welcome back to the Medtronic Talks podcast. We're going to tackle a very important topic today, healthcare equity. Our guests are Karen Shahady. She is Senior Medical Affairs Program Director at Medtronic, and Dr. John DeChapel. He is Chief Medical Officer, Vice President, Medical Affairs of Americas Region at Medtronic. We spoke today about the problem of healthcare inequity. What are the root causes? How can technology be used to bring healthcare equity together to make healthcare more equitable? We talked about Medtronic's work across industries, how they're working with others, what the federal government is doing. We covered a lot. Very important conversation, and happy to have Karen Shahady and John DeChapel here on the podcast. I learned a lot. I'm sure you will as well. Before we begin, I wanted to bring in our sponsor, MTD Micromolding. I'm grateful that they stepped up and sponsored this podcast. This episode in particular, it's a very important issue. And again, thank you, MTD Micromolding, for stepping up and making this episode possible. I spoke with Gary Hulecki. He is CEO of MTD Micromolding. Gary, tell me, what does MTD Micromolding do?
MTD Micromolding is a contract manufacturer for all med device companies. We have a specific focus in medical micromolding. That's all we do. And we do everything here, from material handling to packaging. Products we take on is medical implants, medical components, pharmaceutical packaging. We do prototype, pilot production, high cavitation production. We use standard, any kind of thermoplastics, bioabsorbable resins. All the molding is done in Class 8 clean rooms. We use scientific molding principles, validation processes, IQ, OQ, PQ. We also do cavity pressure monitoring with our JG equipment. We have a robust metrology lab with all kinds of laser scanning, touch probe, CT scanning, and we also do full custom packaging and assembly.
That's great. As always, we'll hear more from MTD Micromolding CEO Gary Hulecki a little later in the podcast. If you want to find out more information about MTD Micromolding, go to mtdmicromolding.com. Now let's begin this episode of the MedtronicTalks podcast. Well, Karen Shahady and John DeChapel, welcome to the podcast.
Thanks for having us.
Great to be back.
Well, I'm glad to have you here on the program. We're here to talk today about health equity and what Medtronic and the medtech industry is doing to, number one, identify the problem, define the problem, but also, of course, solve the problem. It's one that's been with us for decades. It's one that's received new attention as of late, as it should. And I know there are a number of efforts underway to rectify it. So I think the entire discussion would benefit from just a general understanding of what does health equity mean. And Karen Shahady, I was hoping you could start us with that.
Sure. And, we've looked at the CDC definition around this just to say, what is CDC saying about it? And, they really look at making sure that health equity is achieved when every person has the opportunity to attain her or his full potential, and when no one is disadvantaged from achieving that potential because of socially determined circumstances. And so it's trying to look at, making sure that we can close any gaps around access, quality, and outcomes to care. And so we've really been focused on ensuring that we can do exactly that and focus on access, improving quality, and achieving outcomes.
I think it should be self-evident, but it probably isn't. What is limiting that access? How are people being kept from the care they need?
That's what we're exploring right now. And there's a lot of work being done with our operating units right now to say why. We just completed a large market study from our neurosciences business trying to say exactly that. Why? They did a quantitative and a qualitative analysis using data, looking at doing interviews of people to try to figure out, number one, is there a gap? And then if there is a gap, where is the gap? Is it race or is it place? And then why is there a gap? Is it social determinants of health? What's going on? So a lot of our operating units are doing exactly that by leveraging data and analytics to really take that deep dive and figure out what is the problem and where is it, why is it? Because then we can really start to figure out what it is that needs to be done in a more directed manner. And so that's the approach that we're taking now, is put together a framework so that we can really take a more methodical approach to this.
That's great. John, can you sort of, to complete the picture, who is being impacted by this and what does the impact of health inequity look like?
Yeah, sure. So Karen talked about gaps, and it's really important to study where the gaps exist and then understand, if you want to fix the problem, then you have to understand the specific barriers that are keeping people from getting high quality care. And there's some examples that are very well recognized, such as heart disease, where there is a difference in mortality rate between the white population and the Black population of some 30%, or even more marked in things like colorectal cancer, where it's a 40% mortality difference. What we're doing is, outside of those disease states, looking at the other disease states, such as Parkinson's disease, and finding that there's a measurable gap there, and then taking the next step and saying, okay, what are the barriers to care? So first off, I think you have to recognize kind of the potential inequities in care. So ones that all of us go to first would be race or ethnicity, right? And I mentioned that just a moment ago, Black versus white, but there's other potential drivers of inequities or disparities of health outcomes. It can be language, it can be geography, it could be gender, it could be sexual orientation. So we need to take a broad view, come into this open-minded, and then narrow our focus once we identify what the barriers really can be to try to fix it.
Do we have a sense of which way the needle is swinging in terms of between better and worse? You mentioned geography. I'm thinking of rural healthcare is really suffering. A lot of hospitals in less populous areas are being shut down. I mean, we don't seem to be heading in the right direction just based on geography. We can talk about income disparity and other issues as well. But which way are we headed in this?
Yeah, geography, I think, is one of the more underappreciated ones. And to your point, shortages of healthcare providers in more rural settings. It's just unrealistic to expect someone to go drive 3-4 hours to see a specialist who they may have to see on an ongoing basis to get the appropriate level of care. So they end up seeing a primary care physician who, just by definition, can't be expert in every single disease state. And so the quality of care could be different for someone in a rural setting versus someone in a more suburban or urban one. And so we need to think about, if that in fact is a barrier to high quality care, then what can we do about it? Now, there's some new catalysts that are being discovered, such as telehealth, that can start to address that. Remote patient monitoring can also start to bridge that distance gap. So there are solutions, but first we identify the problem, and then we can come with solutions. And maybe that's why Medtronic is so particularly interested in this, because we have unique data analytic capabilities coupled with technology offerings that can make a difference.
Just to add to that, it's great that we have such phenomenal technology with, remote monitoring capabilities, telehealth, et cetera. And, a lot of key stakeholders like the Centers for Medicare and Medicaid Services, CMS, they're looking at whether or not there are gaps in terms of access to the types of technology, internet service, things like that people in rural areas will actually need. So, we keep that in mind as well as we're developing programs and, looking at different populations, because we want to make sure that, again, that's another potential barrier that we want to make sure that we can break down or solve for when we're trying to support patients in their care. It's a very real issue in these rural communities about having bandwidth and access to internet. So something that we're always keeping in mind.
That's a great point. I mean, as we, on this podcast and elsewhere in Device Talks land, where we talk to companies about how they're incorporating new technology, connected care into their products, we just have these discussions sort of with the assumption that they're going to be available to everybody, but we may have the greatest device that can do the greatest thing in the world. But if you don't have access to 5G or something of that like,
right,
then you're out of luck. That's a great point. Well, let's circle back a bit and talk maybe about root causes. Is there a root cause or an origin of health inequity? I will take a quick break from this conversation to bring back Gary Hulecki, CEO of MTD Micromolding. Gary, how does MTD work with medical device companies?
We specialize in designs that have, say, a high level of impossibility. We are an engineering-driven company, so we do design for molding, we do design for manufacturing, we do product design, also help with prototype tooling and bridge tooling to get the process started and to determine feasibility. And we also have the ability to scale up with production manufacturing and full quality system to ensure that these products are delivered to the sterilizer or to a warehouse. And
finally, Gary, I want to know, what is new at MTD Micromolding? What can you share?
Well, this year we've kicked off, a lot of people have done some additive manufacturing. A lot of 3D printing has been popular with med device companies. But the problem with the 3D printing is it's out of a photopolymer that is, if ultimately the part is going to be injection molded, a photopolymer really isn't realistic. It doesn't have the properties of a perfectly homogeneous injection molded part. So you can't really do any high level testing. So what we've done is we've created, for lack of a better term, we've created a mold that we can, say, mold a puck out of the material that is ultimately going to be injection molded for this product, and we're able to machine it. So it gets you a lot closer and than 3D printing, because it is going to be out of the material that is ultimately going to be injection molded. So it allows you to do some, say, higher level testing with the part out of the material that's going to be injection molded.
That's great. Thank you again to MTD Micromolding for sponsoring this episode of Medtronic Talks. Thanks, Gary Halecki, for joining us on the podcast. If you would like to find out more information about MTD Micromolding, I suggest you go to MTD Micromolding, all one word, mtdmicromolding.com. Now, let's get back into this episode of the Medtronic Talks podcast. Is there a root cause or an origin of health inequity?
It can go back through U.S. history, right?
Yeah,
we could do a whole, U.S. history lesson on that. And I think, what we've tried to focus in on is really to say, what is the root cause from a data and analytics perspective? And how can we leverage what we know from better ways of identifying patients for, in particular, disease states to say, are we identifying the right population, the right patients? In the old days, it was easy. You would identify a population based on claims data or EMR data and say, here we have a population of patients with diabetes or a population with disease X. But now we're able to actually stratify that data with some of the newer health equity metrics around race, ethnicity, language, gender identity, sexual orientation, to say, okay, where are the gaps? What is the root cause driving this? And then take it down even further, like we had mentioned earlier about social issues. Are there social determinants at play? Is it around a language barrier? Is it around transportation? Are there economic issues at play? What's going on? And really try to refine what is the root cause driving this so that we can then move on and think about, well, how are we going to solve for that? And how do we engage people? How do we better engage the patient, the caregiver, or the provider? Making sure that we have the right tools and resources for the providers to enable care for their patients. Then we can look at, okay, well, what is the right intervention? Is it a device? Is it a new care pathway? What is that new solution that we can have? And then be able to measure it and say, are we achieving outcomes? And I want to mention there are probably two areas of measurement that are important. First of all is, are we achieving a clinical improvement? In the example of diabetes, say, did we improve the hemoglobin A1C? That's one metric. But are we actually closing that gap? And this is, where we can really start to be creative about how we can measure that. We look at the observed over expected ratios. Medicare has a lot of quality measures that look at observed over expected. We're starting to look at the same. Are we able to close that gap from what we would expect to see and what we're actually observing? Earlier John mentioned, some cardiovascular diseases. And I think it was the Journal of the American College of Cardiology had published back in 2017 some data around patients having aortic stenosis and the percentage of people who were referred for TAVR, the transcatheter aortic valve replacement. And in that study, 83% of people who were referred were Caucasian and 13% were Black. And so these are the kinds of gaps that we're trying to solve, to close. So when we measure, we of course want to measure good clinical quality outcomes, but in addition, are we starting to close that gap so that we can ensure access? And if we're not, that's okay. It just means we go back to the drawing board and we figure it out. And that's why this measurement is so critical, because it's about continuous process improvement. If we're like true engineers, if we don't achieve that result the first time, we want to quickly get back to the drawing board and figure out why not, and then go through that pathway again of better ways of identification, engagement, better interventions so that we can achieve those outcomes.
I was curious about maybe this falls under the intervention, but if a person is not getting access to the treatments that they need because of where they live or how they look or how much money they have, I would guess in most cases, they're not even aware of that there were options to them that were not made available to them. So is there a part of this that is making sure that folks know what they're entitled to and what they need to be advocating for? Is that part of the solution as well?
Absolutely, Tom. Karen spoke before about using the term social determinants of health, and one of those is around education. So you have variable levels of education in the population. It's really beholden on all of us in healthcare, whether we're a manufacturer like us or whether you're a provider like some large health system or whether you're CMS, to educate the population as to the common disease states and what therapies are available to them, what to do to first avoid the disease, but should you have it, what therapies are available. So awareness, starting with physicians and moving to patients, is a critical piece to addressing health inequities for sure.
And the federal government and CMS now are really putting a tremendous amount of attention on health equity. President Biden signed an executive order around really promoting equity across all areas of the government, but Medicare really has picked up on this. And now we're seeing in the proposed rules some new quality measures around health equity. So health systems are really taking a close look at this. As John was mentioning, this is with providers. What are providers going to be doing about this? And in our role, we're really working in lockstep with providers. So as we keep an eye on what policies are coming out around equity, around measurement of health equity, we're working in lockstep with providers, health systems, to say, what can we do in that community to really support them in achieving, improvements in access, quality, and outcomes. And so it's only by working together with providers in collaboration that we're really going to see some movement. And I'll just mention it's partnerships across the whole ecosystem. The device industry, for sure, it's working with providers, seeing what policymakers are doing, patient advocacy groups, it's quality stakeholders. Really, the entire healthcare ecosystem has to be in on this in order to make something work.
I think that Karen spent quite a bit of time talking about providers, and I think that that's really the hallmark of Medtronic's approach to health equities. It actually started with the providers coming to us as there was increasing recognition of health disparities. They've always been around, but they had not been well recognized, as I think we all appreciate, until the last couple of years. And they came to us saying, we want to do something about health disparities in our population, where our hospitals are, but we don't know quite what the next steps are. Do you have some ideas for us? And that's what drove us to really dive deeper into health equity. And we decided very early on that our approach would be a grassroots approach, one where we're working in individual communities for working on a certain disease with a certain hospital to attract a certain population to get them the high quality of care that they deserve. We are undertaking policy work and other maybe more top-down initiatives, but the hallmark of our approach has been grassroots. And one of the reasons for that is that we think we can have more impact. And then the second is that we think it's much more sustainable. If we're partnering with a health system, then that is a way where we can stay involved and engaged and go from the point where we measure the gap, identify the barriers, to a point where someday we're going to be able to come back and repeat that study and demonstrate that we've closed gaps in care. And we can only do that, we feel, if we're in the community taking the grassroots approach alongside of health systems to try to address this vexing problem.
What does that partnership or effort with the healthcare system look like? What are you providing them? Is this a service you're providing them, or are you merely going into their data and sort of helping them understand it better? Or is there something else entirely that I'm missing? Can you give me a little more detail, either of you, on what that actually looks like?
Yeah, there are a variety of things that we're doing. As John was speaking, I was thinking about some work that we did, first looking at the state. So the National Academies of Sciences, Engineering, and Medicine came out with this framework of really an approach. And one pillar of that is to look at the community health needs assessment. So really, it's looking at what is going on in that particular state. Earlier, you mentioned rural health as one area. Absolutely. What's happening in West Virginia is completely different than what's happening in South Carolina and different than Kentucky. And so as we start to work with large health systems, we do some research and say, what's happening in that state? What are the key priorities from the state, from their payers, from the health system? What's driving this? Is it maternal health? Is it diabetes? Is it access? We talked about internet access, so whatever is going on in that community, we start to look at, and then think about what are the resources that Medtronic can offer. So in our diabetes operating unit, what are some initiatives and some solutions that we have to offer that we can then bring to the health system and help be a part of that solution? There's a lot of work being done by providers and these large health systems, and we can be a part of that solution, a piece of the puzzle, to make sure that we're leveraging technology. One of the things that framework from the National Academies of Sciences, Engineering, and Medicine did not incorporate when they did it was around technology. And so we've been talking about the role of technology here and how we can really leverage technology to help in advancing equity across the country. And it has resonated tremendously well with key stakeholders, from quality organizations, leaders at large health systems. They say, absolutely. Because they keep saying, how can we do more with less faster? And so technology is a piece of that puzzle, whether it's on the data and analytics side or providing a technological solution to a disease state. Bringing in that technology component really is critical. And whether it's diabetes, looking at some of our devices that can be offered to patients, and to provide access to them, but also looking at the care pathway. Are there barriers in terms of specialty providers? Are there not enough specialty providers in a particular area? So should we look at primary care providers and work with primary care in that particular region? So our business units are really working hand in hand with health systems to come up with some novel solutions once they figure out exactly what that barrier is.
How does this fit into Medtronic's overall mission? Your overall mission is to improve health and to create products that make people better. But this sort of analysis of how care is being delivered, would appear to me to be in cases where it may not even involve Medtronic technology or products. How does this fit into the company at large? Is it seen as a sort of a public service element that's necessary to be done, or is it part of each of the businesses and it's just part of built into your strategy and DNA?
No, I would say both, Tom. And what I mean is this: is that it's absolutely part of our mission to ensure as best we can that everyone has access to high quality care, and that's what drives the 90,000 employees at Medtronic. But you could also look at it from a pure business lens, and work in addressing health disparities could well be termed market development, right? You're expanding the market. And if you believe that your products can truly offer value or better outcomes for a group of patients that device is indicated for, then yes, you're doing something that is very consistent with your normal business practices, which is engage in market development, but you're also satisfying the Medtronic mission of helping those in need. So they're very much complementary. And I think it's for that reason that I have great hope that this effort in health equity at Medtronic will be sustainable, will be long lasting, because of these two drivers here, both mission and also just the simple concept of market development, which is so fundamental to our business. And if we're going to make changes, it's not easy. It requires the long haul. It's not something where you can just have the Medtronic Foundation write a check and think it's going to be fixed to a deserving organization, right? It requires continued long-term engagement. And so the fact that it is both the mission and also just in a pure business sense market development, I think is something very encouraging for those of us in the area.
And, Jeff has told us he wants us to make sure that this is, whatever we do is scalable, sustainable, and that we're actually making an impact. This is not about writing checks, as John said. This is really about making an impact. And I want to just highlight one other example with Virtua Healthcare in New Jersey, in Camden, New Jersey. And we had worked with this large healthcare system, also had been working with Medtronic Labs, which is a program that has been working out in rural Africa and India for over 10 years and has achieved outstanding outcomes in terms of improving hypertension in those communities. And when we started working with Virtua and hearing about some of the challenges that they face in Camden, New Jersey, we thought about some of the work taking place in other areas of the world and how could we bring in some of that work into Camden, New Jersey. And so we brought labs in to Virtua to see, is there an opportunity to partner and come up with some kind of novel approach at providing outreach and screening to their community. And so now Medtronic Labs is going to be working with Virtua in that community at the Cherry Hill Clinic, providing screenings for hypertension and diabetes to bring people, back in and keep them connected with their providers. And it's a novel approach because they use a phenomenal platform system. They use community healthcare workers. It's really filling in a lot of gaps. And we're really excited about this work taking place in Camden, New Jersey, and are looking forward to seeing the types of results that they can achieve there in, again, improving access, improving quality, and really driving those outcomes.
We look at this as two stages. We look at patients that exist in the community, and then we look at patients that exist in the health system. And the biggest problem is getting people who are not currently in their local health system into that health system. And so having an outreach arm like Medtronic Labs doing screening, as they've done in India and Africa, and now doing it here, in the U.S., in these minoritized populations has been critical. And now it enables us to go to the next stage, which is once they're in the system, then to offer them to make sure that they're getting the same quality care. So they've been identified, they're in the system, and now they can enjoy the benefits of technology. We spoke earlier about technology, and technology can do one of two things. It can divide the haves and the have-nots. We were talking about internet and 5G earlier, or it can democratize and it can enable everyone to get a similar high quality result. So if we can get folks, for example, with diabetes into the system, and we educate the physicians in the system to the value of a technology such as continuous glucose monitoring or to a automated insulin delivery system, we know that we can improve their blood sugar and decrease complications related to diabetes. People who are affluent, they probably would normally go see an endocrinologist who would be very much aware of these technologies. But people who are not so will have to first be brought into the system, secondly, be treated probably by primary care docs who will have taken upon ourselves to educate to the value of the use of technology to improve their average blood sugar. So it's a multi-step process, starting in the community and then getting those patients who are in the health system the same level of care. And that's how we think we're going to start to see success.
Two more questions. One, looking internally, do your efforts inform either product development or clinical research? We talked earlier before we push record, Jennifer Doyle, Vice President of Clinical Research and Medical Science at Medtronic. We had her at our Device Talks Boston meeting talking about improving clinical trials through broader representation. Does any of what you're working on create information for your colleagues who are developing and testing new devices to make sure that they're being tested against an accurate representation of the population?
Absolutely. That is, we take a multi-pronged approach to addressing health inequities, and we've spoken a lot today about our grassroots provider partnerships, but there are other aspects. One of them is taking an honest look at ourselves and saying, do we have adequate diversity in the trials that we sponsor? And really that critical look has demonstrated that in some places, in fact, that wasn't the case. And what are we going to do going forward to recruit patients into our trials that represent the true population who has that given disease? So we're holding ourselves accountable for ensuring that we have clinical trial diversity. And even before we get to the trials, we also have folks who are designing our products, human factors engineers, thinking about different populations and different races, ethnicities, whether they be the provider or the patient, and making sure that we are keeping in mind the specifics to each one. I'll give a small example. I'm a surgeon, and we are seeing more and more women surgeons. In general, women wear a smaller glove size, they have smaller hands, and yet our older generation staplers were really hard to close if you didn't have a big, strong hand. So we have our human factors engineers have taken that into account and have reduced the size so that women surgeons, Asian surgeons can use the device with the same outcomes as a larger person, let's say, may have in the past. So it starts with our engineering. It extends to diversity in our trials, and then we go from there with the other items that we spoke about in terms of addressing the barriers that exist out in the community.
And Tom, just to add to that, there have not been great benchmarks out there in terms of diversity in clinical trials. What's the right number? And so we have joined Medtech Color, which is this collaborative organization with other industry and device leaders to do exactly that. Let's find out what could we create as benchmarks? What should they be? And so we have representation there. We have internal committees working on this, as well as the operating units, as John was just describing. One other area of this, how do we get that information out across Medtronic? We created an internal group called our Health Equity Advisory Committee, comprised of leaders from various operating units, some of our employee resource groups. We have representatives, different functions, whether it's compliance, healthcare economics and health policy, government affairs, all coming together and sharing best practices. And you have never seen a more engaged group on that committee that stays focused, comes to every meeting, loves to hear what's going on, shares best practices. I mean, the technology that we have is, of course, phenomenal. And the designs that John just described are outstanding in that we have engineers who are listening to what's happening in real life and how can we adjust and modify that. But it's the 90,000 people behind that make it work. And that's what I think has been so unique and so inspiring for us to see at work through this Health Equity Advisory Committee. It's not just about looking at data and let's fill a gap and what can we do here or there. The passion and engagement of the Medtronic employees has really been inspiring as we've, taken this on and continue to do so. We're thrilled to do it. And we look forward to seeing, what is to come in the years ahead.
That's great. And that leads well into my final question, which was the externally directed question. Where does Medtronic fit into the broader industry effort to combat health inequity? It would seem that if you have a large forest fire, you want to coordinate your efforts to put it out with other firefighting companies. Is Medtronic working closely with government agencies? Is there sort of a broader industry-wide effort that you're part of? How does your effort fit into the broader attempt to battle this?
We're doing some of that, with AdvaMed, the Industry Trade Association and, partnering on some committees there. That's one piece of work. Medtech Color, as I mentioned. The various operating units are also very engaged in their respective specialty societies, whether it's the American College of Cardiology, for example, being engaged with specialty societies is important, and also other key healthcare stakeholders like T1D Exchange for the diabetes group. So you see our operating units really taking the lead with some of the externally focused work with key healthcare stakeholders. So I think it's really across the board, at a national level, we're doing what we can. We're talking to other organizations who you might think of as competitors. We're talking to say, what are we doing and what can we do together? So those conversations are absolutely happening. So it's really internally as well as externally and at local levels as well as some of the national levels to really try and tackle this. As we learn, we're all learning together in this right now. And, each week, each month, we learn a little bit more. We know a little bit more than we did last month. And so it's just been growing and growing over the last several months.
Karen may be too modest to mention one of our most important external collaborations, and that is she represents Medtronic sitting on committees that formulate quality measures and has been vocally advocating for the inclusion of health equity content to be put into those quality measures. And it's those quality measures that are created and then ultimately recommended to CMS that will absolutely drive change in behavior of health systems across the country when their finances, to a degree, will be dependent on satisfying quality measures that have a significant health equity component. And we expect private payers to soon follow on if they have not already. So that's another key piece, is that health equity is the right thing to do and is also the financially advantageous thing to do.
Great. Just final question, Karen. Do you have a sense of what success looks like? Is this just something we need to keep doing forever? Do you have an idea of where this needs to lead, or are we not there yet?
It's a great question, Tom. We have a role to play, and success, across the board is certainly to make sure that, as we started off the discussion, to make sure that everybody can attain their full potential and that they're not disadvantaged. That's really that utopia. But if we can start to close some gaps and show that our interventions are moving the needle, that's the first step. And that we really want to see some outcomes and see that impact and make sure that we're doing this at scale, so it's sustainable, and that we're really seeing some outcomes. And for us, I think that would really be one definition of success, to make sure that we can really improve access to care while improving quality and really driving those outcomes. And once we start to gain some traction, we'll start to learn more and more. And, like any good predictive model, we'll learn from what we did in the past, and then we'll maybe copy and paste it to something else, and it will start to replicate. So I think we're just at the beginning stages of this. And once we can see what works and let it start to replicate and catch fire, I think that would be success.
Terrific. All right. Well, this is an excellent discussion. Thank you both for your work in this effort and for joining us in the podcast.
Thank you, Tom.
Thank you, Tom.
That's a wrap. Thanks again to MTD Micro Molding for sponsoring this episode of the Medtronic Talks podcast. Thank you to our guests, John DeChapel and Karen Shahady, for joining us. And of course, thank you to you, our listeners. Please do us a favor and follow this podcast on your podcast player so you don't miss a future episode of the Medtronic Talks podcast. You can also find it on Medtronic.com and DeviceTalks.com. But if you subscribe, it'll be sent directly to your listening device. We'd also be grateful if you would share this podcast episode on your social media channels. And when you do, please connect with me. I am on LinkedIn, Tom, Salemi. I am the editorial director of Device Talks. You can also find me on Twitter at MedTechTom. Well, once again, that is a wrap. Thanks again for joining us. Thank you, MTD Micro Molding, for sponsoring. Thanks to our friends at Medtronic for making all of this happen. Tune in next time. We'll have another great episode of the Medtronic Talks podcast waiting for you. All right, Chris Newmarker. Now is a time when we tell our friends, our families, and our Device Talks listeners how they can find us on social media. Hopefully our friends and families know how to find us on social media. But
I usually tell my family to communicate with me over social media.
Son, you connect with me on LinkedIn?
Dad, I got some questions about send that to me on. Oh, you don't know how to write yet. Well, okay, I need to get back on LinkedIn, son. But yes, you can find me on. Even if you're not my family, you can find me on LinkedIn as Chris Newmarker, just like a Newmarker. Always happy to talk to people.
And on Twitter, you are also Newmarker,
yes.
As in a Newmarker.
At Newmarker, yes.
Or at Newmarker, yes. All right.
Yes.
And I am on Twitter at Medtech Tom. I'm on LinkedIn, Tom, Salemi, like Salem with an I at the end of it. And please do reach out to us. Please do connect to us when you share this podcast episode on those social media channels. And of course, please do, what do we want folks to do, Chris?
You got to like, follow, subscribe.
Damn, that's good. You're just that's sharp. You just got that.
Somebody thought we had a recording of that.
I was hammering.
Yeah, all right. Yeah,
Ooh.
Come on, Jim.
No, we are organic here. We are free range podcasters. Yes, like, follow, and or subscribe on any podcast application, and you will not miss a future episode of Device Talks Weekly, or our Stryker Talks podcast, which went out yesterday, or our Intuitive Talks podcast, which we're gearing up to do again. And if you'd like to subscribe to Medtronic Talks, please, they have their own channel. Go to Medtronic Talks on any podcast player, and you can have episodes of Medtronic Talks sent directly to your phone as well. So much medtech, so little time. Really,
yes.
We're doing what we can here to.
You're missing out the wealth of medtech information we are providing.
A veritable fountain, a geyser of insights and entertainment. So
yes, when are we going to start our 24-hour channel?
I think
I'll work 12 hours in the day and you can work 12 hours a night. How's that sound?
That sounds fantastic. Yeah, we need to do Twitch, right? We need to Twitch this puppy. Yeah, so people can see us do this stupid podcast.
We turn into like, here's Chris sitting down writing an article.
That's right. Oh, hi. Eating a potato chip. Anyway, all right, there we go. That's a wrap, folks. Thanks so much for joining us on this episode of the Device Talks Weekly podcast. We'll have another full-fledged Device Talks Weekly podcast episode waiting for you next week.
Hey, everybody, just, turn off the news alerts, enjoy the weekend, enjoy the summer.